Hi, good afternoon, everyone. Thank you for
Oh.
joining the second session in our age-friendly geriatric education tele-echo series, Enhancing Your Client Health Check. This series has been organized. Let's mute this. Hold on one second.
Sounds good. Bye.
If you guys have any background noise going on, make sure you mute yourself, please. Thank you. This series has been organized for you by UC Irvine's Division of Geriatric Medicine and Gerontology in partnership with Meals on Wheels California. So thanks so much for taking the time out of your day to join us. Today's topic is going to be focusing on mental health in older adults and social isolation. The session will be recorded as it was last time, and the link to the recording will be sent out early next week. So if you have anybody you'd like to share it with, please feel free to do so. This is the structure of our echo sessions, starting with our announcements and introductions, and then we're going to be followed by a quick 30-minute didactic, and then moving on into our case discussion with collaborative discussion, followed by our closing and reminders. As a reminder, just remember to please mute yourself when you're not speaking to prevent background noise. Introduce yourself with your name and location prior to speaking. And then always maintain confidentiality when speaking about your clients and refrain from including any identifying information, and then respect others and their opinions. This series is approved by the California Board of Registered Nursing. You will receive a CE certificate at the end of the series with the total amount of CEs you have received in the series. Please be sure to complete the CE form that we sent you via email after each session if you'd like to receive CE credits. Certificates can be submitted to your own licensing board for reciprocity, and many do see PRN CEs as transferable. You must attend the full hour for credit per session. As a reminder, our series is a part of our HRSA Geriatric Workforce Enhancement Grant at UC Irvine. This information or content and conclusions are those of the author and should not be construed as the official position or policy of HHS, HRSA, or the US government. Again, we truly thank you all and Meals on Wheels California for your partnership and all that you're doing to serve the community and older adults in your communities. So we're going to go ahead and move on into our introduction as we do at every session. Please take a second, if you have, to introduce yourself via the chat function by listing your name, your role, your site, and your location. We'd love to see who's on the line at the moment. So please go ahead and set in chat, and we'll have introduce themselves as well. So I'll go ahead and get started. My name is Nika Seville. I'm the project manager for our Geriatric Workforce Enhancement Program at UC Irvine Health, and we're located in Orange County, California. I'll go ahead and move on to Dr. Sagal.
Hi, everybody. I'm Sonia Sagal, and I'm an internist and geriatrician at the UC Irvine Health Center. Welcome.
Thank you. Dr. Gibbs?
Hi, Dr. Gibbs here. I'm the Chief of Geriatrics at UC Irvine. Welcome, everyone. Thank you.
Geraldine Date?
Hi, I'm Geraldine Date. I'm a licensed clinical social worker in the Senior Health Center at UC Irvine Medical Center. Thanks for being here.
Thank you, Geraldine. And Carlos?
Hi, everyone. Happy Friday and welcome. My name is Carlos Garcia, and I'm the data analyst for our Geriatric Workforce Enhancement Program.
Wonderful. Thank you all for joining and for introducing yourselves. I see a lot of people on the line from Sacramento, San Francisco, San Diego, Orange County, Santa Ana. Thank you guys all for joining us today, and we'll go ahead and move on into our didactic presentation, which is mental health and social isolation in older adults. It's going to be presented by Geraldine Date, licensed clinical social worker at UCI Senior Health. Again, please remember, if you have any questions along the way, feel free to raise your hand or post them using the chat function, or you can save them until the end of the didactic where Geraldine will be happy to answer your questions. So I'll go ahead and have Geraldine take it away.
Thanks, Nika. Everybody, I want to welcome everyone back. Thank you for being here on a Friday afternoon, and a warm welcome to those who are just joining us for the first echo, for their first time in echo this series. So welcome, everybody. In the next half hour, I want to invite you to have a discussion about mental health and isolation. I gathered 3 talking points from my colleague, Dr. Gibbs, who presented during the last meeting. And I'll use that as a segue into some of our topics today. I will be covering what is mental health, key issues, identifying symptoms, social isolation, the good, and interventions. So let's get started. All right, so Dr. Gibbs invited us to think about the unintended consequences of social distancing and the lockdown guidelines, dealing with the added challenges of loss of caregivers and lack of access to community partners like senior centers and adult day programs. The intent of the guidelines was to keep older adults safe and healthy. The unintended consequence is social isolation. We were already seeing an uptick pre-pandemic of really self-inflicted isolation of agers who were not wanting to impose on others. And now with the mandated confinement, the lack of external stimulation fuels, and it really takes a toll on the physical and mental health of agers. And so the other point that Dr. Gibbs made that I thought would be really important for part of the discussion today was her mentioning the pandemic will be remembered as a tragedy. That really spoke to me. And she discussed TIC, trauma-informed care, as a tool to guide responses to the pandemic. So the framework of trauma-informed care is to recognize that there are known phenomena after disasters. Increased mortality, morbidity, depression, anxiety, suicide, substance use and abuse, increase in violence, and just more health issues like heart attacks. So the impact of trauma can be buffered by making connections with others. So for me, it would be our patients, and for others, it would be patients as well, or clients, over making connections over things like health, about and knowing things about things that matter to them, like food insecurity. So talking over things like that help make connections. And in the case of the pandemic, there's a foundation of shared experiences, which allow both parties, me and my patient, or one and the client, to share connections and vulnerability in an intuitive kind of way. So that's what's unique about the pandemic. Sharing vulnerability and transparency is really key to trauma-informed care. Trauma-informed care encourages us to be open and collaborative in addressing concerns. It's I think of it as a what happened to you versus a what's wrong with you approach. This approach can be useful in understanding appropriate services and helping facilitate the needs of our agers. One important issue that I'll be covering today is mental health. And given the enormous influence of COVID and the pandemic, I like to offer a basic discussion about mental health. Okay, mental health. So mental health includes our emotion, psychological, and social well-being, and it affects how we think, how we feel, and how we act. And we all struggle with it from time to time. So I want to break this down to 3 topic points: mental distress, mental illness, and just mental health. So what is mental distress? So this is caused by something that is troubling, something out of the ordinary. And stress is not necessarily always bad. There is eustress and distress. I'm just wondering if you've heard of eustress, spelled E-U-S-T-R-E-S-S. If you've heard that, can you put a 1 in the chat? Okay, great, thank you. So there's about 10% that have that is aware of this concept of eustress. So eustress versus distress is it's a positive kind of stress. Eustress feels like stress that you know you can handle. So for example, eustress is different than distress. Well, maybe it could sometimes overlap. So if I forget my mother-in-law's birthday, it feels like stress, but I know I can handle it. So I would put that in the category of eustress versus distress. Does anybody have another example maybe of eustress? I think somebody was mentioning that their dog just had puppies. Is that right?
That's right. Yes.
Yes. And
I was mentioning that.
That you just welcome some new puppies, and that is I'm sure that's stressful, but that's a positive kind of stress.
Absolutely, yeah. It keeps me up at night sometimes, making sure that the puppy doesn't squeeze. I mean, the mom doesn't squeeze the puppies.
Yeah, absolutely. Thank you for sharing that. Yes, absolutely, Vicki. Thank you. First day of school and you're excited, but a little nervous. You could get over that. Roller coasters, absolutely. Right? You put yourself on that and you can see the end, you go through the ups and downs, and that is something that you can handle. So those are great examples of stress. The flip side are situations that feel overwhelming and may result in unsatisfactory outcomes. And so when you don't manage your distress, it becomes overwhelming, and the risk for mental health problems and medical problems increase. I'm going to move on to mental illness. Mental illness is different. It's associated with distress and our problems functioning in work, social, or family activities. There are ranges of conditions ranges of conditions under the umbrella of mental illness, but it is different than mental distress because mental illness, there's a standard of criteria to a diagnosis. And the US Department of Health and Human Services has a website, mentalhealth.gov. And if you go there, it'll tell you there are ways to maintain positive mental health. Some of their ideas are to get professional help, connect with others, stay positive, get physically active, help others, get enough sleep, and develop coping skills. So the government is really interested in helping us maintain our good mental health as well. They set up this website and they've given us some tips on how to do that. But how do we really apply? How do we really do this? How do we make this happen for agers? It's great to get bullet points. It's great to know, hey, we need to get more sleep, develop coping skills. But how do we do that? So that brings us to our key issues, identifying some key issues here. Okay. We want to know what our risk factors are, increase awareness about mental health disorders, and improve access to services. So the first thing we want to do is to identify risk factors. Increasing awareness about mental health disorders, talking openly about mental health is important. But when you talk about somebody's mental health or mental distress, it can feel really overwhelming at times. So somebody may say, I feel depressed, but don't let that overwhelm you. Be calm and hold space. There may not be a diagnosis. They may just have symptoms, but no diagnosis. You can build awareness of what's going on by holding space. So let's talk about this concept of hold space. So as a social worker, many of you are, we have many times been told to meet your client where they are at. And this is what we do. Holding space, hold space is meeting, not judging where your client is at. Holding space refers to a mental and emotional environment you are in with another person. To hold space, it's a conscious act that allows us to practice empathy. And we'll talk more about examples on what you can say, and we'll talk about specific ideas and tips when we talk about depression and anxiety. The third issue is trying to help our agers with positive mental health is to improve access to services. Okay, thank you. Okay, so we have to understand risk factors. So I'm going to talk about social support, emotional support, mood, anxiety. As a social worker, I need to understand the ecosystem of my patients and their families. Who are the folks in their orbit, informal and formal supporters? For many agers, there's a formal partnership. And an important one because Meals on Wheels attends in their space. You feed them, you offer a tangible solution to an important human need. Because of the relationship with Meals on Wheels, our ager, they'll be open and more open to connecting with other formal supporters. So, such an important partnership. Emotional support, I think, happens from simple hello. How you doing? Nice to see you. Isn't it nice when somebody offers a warm greeting, a smile, eye contact? So nice. Emotional support, I believe, starts there. And when we build rapport, we discern if there's a need for a phone call or a clinical intervention. And we assess whether somebody is in eustress or distress. But it starts with a simple warm greeting. Mood and anxiety happens by holding space. What I mean by that is the assessment of it to get a pulse on the risk factors for mood and anxiety really starts with space. Listening to what they are saying. So some of the things that you may say to build rapport as somebody is talking is, wow, that sounds tough. Do you want to talk about it? Do you need to step outside? And just helping somebody understand that what they're saying is being heard and that they matter. So something as simple as, do you want to talk about it? I think could go a long way. So in our clinical practice here in the Senior Health Center, myself, some of the doctors, and definitely our physician assistant, we make home visits, and it allows us to become even more aware of the needs of our patients. When I make a house call, I'm always very cognizant that I'm looking through the lens of safety first and foremost. And the social determinants of health that my colleague Dr. Gibbs mentioned during our last meeting is key to really understanding and having a space to practice awareness. And some of those social determinants are assessing what their life space is. Is it safe? Do they have financial means? Are they struggling? Because I need to know what their environment is. I need to be aware of their environment to offer congruent and helpful resources, whether it's for mental health or some other issues that they might be dealing with. I certainly want to know if health literacy, for example, is an issue before I give them a handout of something that is important for their safety. So awareness becomes really important. In doing an assessment of awareness, it also helps me build confidence in the way the conversation may be flowing. Awareness builds confidence for me to know what the next appropriate steps might be to be helpful. I also wrote on a tip here that avoid reacting to their level of urgency. People want to be heard, and so they really want to make their issue, sometimes they actually speak loud, they talk fast, and the awareness, the self-awareness that you can have in situations like this is to not react to the level of their urgency. So what I do sometimes is to literally put some space between me and a phone call. I might put them on hold just for 30 seconds so that there's a forced quiet space where we both breath. I may physically remove myself and say, I'm going to just excuse myself, I have to get something from the car or something so I can create some space to breathe. Because people's level of urgency to want to be heard could really create some challenges. So I would make sure that I'm aware not of what else is going on with the client, but also with myself. So that is 3 points that I would recommend for having awareness. Two of the most common mental disorders, clinical depression and anxiety. Okay, and let's talk about some of the symptoms. Next slide, please. Okay. So this is important for me to offer symptoms of depression, but I think what's equally important that I want to offer in our time together today is just to reiterate what many of you, all of you do when talking with patients and clients, is that there is a tone, a place a space that you create, which is filled with warmth and genuineness. You know, we know when somebody is genuine and caring and warm. Looking at people again in the eyes and not minimizing will help with whether you're clarifying symptoms of depression or just being in space with somebody so that you can get them to the right people that can help them with dealing with some of these symptoms. So in creating a heartfelt, genuine space, some of the simple words that I use are things like, thank you. I care about what you're saying. I'm sorry. I am here to listen. You are important to me. So those are some of the words that I use when dealing with somebody, when I think that they are dealing with some mood issues, whether it's diagnosed or they're just symptoms. Are there any other simple words that you all use to help somebody that might be showing symptoms of depression? I would love to hear that. If you want to say it or put it in the chat, that would be wonderful. So I'd love to invite you guys to share some of your.
This is Valerie. I sometimes will use a phrase, or I will use a phrase that says, I can see this is hard for you. If there's something I can do to help you, or things like that.
And validating, it sounds like, what they're saying.
Definitely. And sometimes in our visits, things come out that is unexpected, that you're talking about one thing and then all of a sudden you see they're kind of breaking down. And so it takes a moment. I'll stop typing or, and do what you're saying, kind of just pay attention to them, look at them directly in the eye and continue through with the conversation, really being one-on-one with them.
And holding space is what it sounds
Yes.
like you're doing. I think that's terrific.
Yeah.
Your feelings are valid and they matter to me. And that was another comment. I feel I'm always tempted to say, I know how you feel, and yet I know that isn't right. Yeah, we're human, and we want to empathize and say, oh, I know how you feel. But I think I wouldn't be so hard on yourself. I think what the genuineness in your tone and the authenticity in that moment, I think is equally important. And I bet you do a terrific job with that. It's understandable you're feeling this way. That's a really good one too. Would you like to speak to somebody? Absolutely. Oh, that makes, you're feeling horrible, labeling how they might feel. So yeah, absolutely validating. I hear you. That sucks. Like that, you are going through something that's really difficult. I think those are all really good examples. Thank you guys so much. I often have to remind myself that my job is not, sometimes my job is not to fix the situation, but to listen intently and kindly so that I can get them to the right people that can fix or help. But I try, my personality is so that I try to fix. And so that, I'm kind of always checking myself there, but helping just be in the moment and listen is really important. Something else I'd say is, sounds like you're willing, at the end of, oh my gosh, where am I going to go with this? I say something like, sounds like you're willing to get some help, and leading into whether it's next session or a handoff to somebody else. For anxiety, my questions are a little bit different. It's I try to create more calming questions, and I might model more calming behavior. So I may sit, and when I'm listening, I'm paying very much close attention to the way I'm breathing, because the way we breathe may be contagious to those who we're having a conversation with. I know that when I see somebody yawn, I yawn. So, if I'm talking to somebody who is anxious, I often sit, I present pretty calm as I can, and I take some deep breaths. and I might have more questions for them than statements. So I may say something like, can I sit with you? Or what can I help you with today or right now? What can we do together? And so it's very focused, it's very leading, and I try to find a calming segue into our question. And I always tell folks, take your time, take your time. Okay, next slide, please. Okay, so I have a case example. Mrs. H is 68 years old. She and her partner both retired 10 years ago. They had always wanted to learn to fish, and all was going well until there was a fishing pole accident and Mrs. H lost her left eye. During her recovery, her partner suffered a stroke and died. A lot going on there. So with this example, what I would do is, if I was visiting her, I would hold space. I would let her keep talking. I would say validating things like, I hear you. That sounds really sad. Can you tell me more? And comments like, I understand. So it just really validates, keeps the conversation going and validating what you might be hearing. So a lot of things going on, grief, loss, but underneath it all, it's really about listening and trying to triage how we can help prevent her from social isolation, because that is what I was really worried about when I met with Mrs. H. Next slide, please. Okay. Okay. So an isolated person is has an isolated brain. So we want to make sure that the cognitive effects of prolonged social isolation, that we recognize this. And so we want to activate as much as possible to get people of what's going on in their ecosystem. Fewer social contacts equals greater decline in cognitive function. We know that when there's fewer social contacts, problems with reasoning, remembering, navigating. And so we want to pay closer attention to making sure that people are socially staying connected. And there's differences between loneliness and isolation. Next slide, please. And 1 in 4 adults age 65 and older are socially isolated. Important data. Okay, coping with isolation. Okay. So it's really important to be able to distinguish between loneliness and from isolation. Does anybody have some thoughts on that? Any questions so far? Any thoughts? So loneliness can be the underlying case of social isolation. It's the emotion attached to a outcome that we can prevent. And the good news is, and we'll talk about good news, is that as society starts opening up, we'll have more opportunity to be engaging so we can mitigate the loneliness and hopefully increase socialization and connectedness. Important, again, taking inventory of who your orbit is, who is in your circle. So as a provider, you want to know who you could partner with in terms of keeping our agers safe, partnering with Meals on Wheels, partnering with adult protective services when needed, and creating a team for our patients and our agers to make sure that they're able to, in a very linear and healthy way, activate services so that we can mitigate isolation. And sometimes what we find is that our patients there's a technology gap. So during the pandemic, we found that coping, we would tell our patients, log on to Zoom, let us tell you about support groups you can sign up for. But what happens is that there is a technology gap at times, and it really does not feel inclusive. And so what we want to do is to, again, hold space, hear what people are saying, understand, assess, and maybe it is something simple like letter writing or doing something by phone and building structure that's individual to the patient or the client so that isolation is addressed in a very personal way. So there's good news. Good news is that we're going to continue to be able to build relationships so we can mitigate mental distress, so we can address mental illness, we can maintain good mental health. Mental health is really about connectedness, relationships. Clinical interventions are available. The good news is things like depression and anxiety are treatable. And so we get to have opportunities to talk about clinical intervention when appropriate as we build relationships and rapport relationships with our older aging adults. And there are treatment options. And treatment options really are at the foundation of treatment options and clinical interventions is really about educating ourselves as conduits of are isolated or dealing with mental health issues to be able to give them current and reliable resources and information. I do have some helpful links and resources for you that I hope you'll consider. I really like this one. It's from NIH, and it's really one flyer that's checkbox for who may be at risk and tips for staying connected. It's a great tool for assessing and addressing loneliness and social isolation. There's also these wonderful tips and hotlines for suicide prevention, crisis hotline, and there is another one called Cal Hope. I don't know how many of you guys have been on that website yet, but definitely check them out. It's a wonderful, well-organized resource that's going to help with mitigating isolation and really addressing mental health issues. So my last tips here are encouraging older adults to stay connected with their primary care physician. Really, really important to maintain that. And I don't think people talk to their pharmacists enough. So when they go pick up their medicines, I would, encourage them to say hi to the folks at the pharmacy. They can be a really valuable asset. And also just the basic hello, isn't that always nice? So when you get a chance, I would encourage everybody to greet and be greeted.
Thank you so much, Geraldine.
All I have. Thanks, everybody.
Yeah, I know we're kind of running low on time, but if anybody has any questions for Geraldine, please go ahead and type it in the chat, and I'm sure she'd be happy to answer your questions. I do want to move on into our case overview. So again, big thank you to Geraldine. But we do have a case to go over that was submitted by Meals on Wheels volunteer Ann Brunner of St. Vincent Meals on Wheels. While Ann is giving an overview of her case, I want you to please think about follow-up questions you might have for her. Think about how do you handle the case or resources you have at your site to assist this client, or pull from the past experience working with your clients as well. So think about those things as she's doing an overview of this case, because it is a collaborative discussion afterwards. So Ann, let me go ahead. Are you here, Ann?
I'm right here. Yes.
Okay. Okay, let me go ahead and share my screen so people can see the case, and then you can give us a quick overview of this case so that people can kind of weigh in afterwards.
Okay. My client is an 84-year-old woman. She is wheelchair dependent after a stroke paralyzed her left side 9 years ago. She manages an electric chair. She lives alone in a small 1-bedroom, 1-bathroom house. A caregiver takes care of her and her needs, specifically bathing, laundry, preparing her bed so she can get into it at night, and house cleaning. The caregiver is there Monday through Saturday, 10 a.m. to 3 p.m. She is very independent. She's mentally fit. However, her physical ability to do what she has managed to do over the years is deteriorating slowly. She puts herself to bed utilizing a manual wheelchair and a 3-legged walking cane. She needs to use the bathroom during the night and uses the walking cane she takes a step and then she drags her foot and takes a step and drags her foot to the nearby bathroom. She recently acquired a portable toilet for her bedroom. I don't know if she's using it. She used to ride the public bus to go out and also utilizes access for her transportation needs. During the COVID pandemic, she only goes to the doctor's office at Kaiser. She has been vaccinated. I have noticed that she has had minor memory issues. She says she is perfectly happy at home. She spends her days watching Westerns, jigsaw puzzles, napping, paperwork, and visiting with friends and family on the telephone. She does not have internet or a computer of any kind, and she wears a medical alert when she is at home alone.
Thank you, Ann. For everyone here today.
What are the signs that would indicate that she should no longer be living by herself? She's by herself all night long, and she has fallen. What do you think?
So
Okay.
what a great case. Thank you for bringing that. And what a great description that you provided us with. So thank you so much.
You're welcome.
I would invite you to really think about this from the lens of safety. What sort of, when you do that, it sounds like, so she's a fall risk and she's fallen. What else would you notice?
Well, she doesn't, so she only has the use of one hand.
Mm-hmm.
So she has a phone, a smartphone, but even to manipulate the phone, it's very difficult for her. So just to slide a screen or to push a button, or it's always, everything is a challenge, everything. Turning on the stove, reaching for toilet paper. And she can't leave the house. She has a ramp at the front door, and somebody has to put the ramp down at the front door so she can leave the house. So unless there's somebody there to do that, she is in that house and she cannot leave.
Mm-hmm. We have some questions too coming in through the chat. So has she shown any signs of neglecting any personal needs? And also, how involved is her family?
She is not neglecting any personal needs. She has a son who lives in Pasadena. She lives in Los Angeles. So he's quite a ways away. She has gotten used to using Amazon with my phone, which has been a help actually. And she has fun shopping on my phone for needs. She's not shopping for things that she doesn't need. So those are things that are delivered right to her door. I think my biggest
somebody
concern is at
suggested
night when nobody's there.
It says, Charlotte says in the chat, it sounds like she might need a higher level of care. Does she have financial resources to pay for part-time or full-time caregivers?
I would say she has the financial resources, although I'm not positive, but she has her son who I think can help her. She's very independent. She's strong-minded. She's a brilliant person. Mentally, she's fine. She doesn't want to give up her independence. So trying to talk her into something, it has to be done carefully.
She has capacity.
I'm sorry?
She has capacity.
Yes.
Okay. So she, you know, she sounds like she may have the capacity to make not just good decisions, but also bad decisions.
I think you're right. She's very strong-willed.
Yeah. So you can prepare for a crisis. So she's not in a crisis yet, but if she
The crisis waiting to happen.
Right, but if she is activating her right and practicing her right to make a good or a bad decision, and she has the capacity to do so. And somebody made a recommendation of, you know, a home safety assessment by the PT and OT. I think that's a great idea. Having a family meeting, talking about, you know, does anybody else see this as a problem? Does the family see this as a problem? Is there somebody she leans on and she trusts other than you that she's listening to? And maybe come up with a plan together for maybe not today, tomorrow, but for 3 months or 6 months, and continue to have a care plan that meets regularly some goals of care that you get her might be something that I would suggest. But, you know, again, the idea that she has the right to make a bad decision, I think is a tough one, but one that I think we need to respect.
And a lot of people are in the chat, you know, really advocating for a lot of different resources that might be helpful to her in the home while she's there. So things like Alexa or the speakerphone on her landline, maybe like a home match roommate. That's what somebody's recommending. Things like that while she is in the home alone to just assist her further.
I like the idea of a home safety assessment. That's a great idea.
I agree.
She can't have an Alexa because she doesn't have internet. And her house is a very old, tiny house with very thick walls. And I tried to do, what do you call that when you can use your other device to take the internet from your phone, whatever that's called. It wouldn't work because her walls are so thick. I think that's another issue with the elderly is we need to have affordable internet for them. She doesn't want another monthly bill to pay.
And somebody else wrote, I'm interested in the acquisition of the portable toilet that's now in her room. Is it something that she bought herself because she recognized that she is having difficulty moving around from her bed? And does it mean that she's somewhat safer at night, not having to walk far to get to the bathroom when sleepy?
So she's started to be incontinent, and that's part of the reason she got the toilet. I'm not sure how she got the toilet. And I don't know if she's using it, but it was her choice to get it, so that's a good sign. Still means she has to get up out of the bed and use it and get herself back into bed. I mean, the process for her to do that probably takes a good half an hour.
Yeah, we have some really great suggestions coming through, and Christy said it sounds like she's really holding her independence as a top priority, and also sounds like she's willing to implement some harm reduction strategies like Meals on Wheels, the medical alert, the portable toilet, a caregiver, regular contact with her family. So we shouldn't forget all those adaptations she has agreed to thus far, and keep giving her those other options and ideas. Because she sounds like she's being pretty resourceful. Now, I know your main question, Anne, was what are the determining signs of moving from independent living to dependent living? I don't know if we've really answered that question. What are some of those signs if we start to see certain things? To our hub team.
Besides the phone call that I'll get someday that she fell in the bathroom and hit her head on the sink or something.
I think when home is no longer safe, you know, I think as our needs evolve, home may not be where all of her safety needs can be met. So it's not really about anyone's needs or wants. It's really, if you look at this simply as a clinical issue, and her needs are evolving, where she lives may need to evolve with her needs. And so really starting from where she is at clinically and doing an assessment with the OT and PT. I know that Kaiser, I think this patient is with Kaiser, correct?
Yes.
That they have their own home health services, and activating them to come out, I think would be a really great start.
Another great idea. Thank you.
I think it's important. Someone mentioned in the chat regarding whether she would be able to manage herself in an emergency. So a fire, earthquake, natural disaster. And I think when it becomes dangerous or the patient's unable to handle that type of situation, either physically or mentally, that from that conversation, because in Southern California, there are things that can happen. So that would be one. And then two, as her, maybe, encourage her to have her providers maybe engage her son and have a family conversation, or engage her son and see where he is and how he feels about mom's safety and whether he has concerns as well.
Okay. I think I will talk to her son. It took a long time for him to feel that I was to be trusted. And I think I've finally crossed that bridge. That took a long time. And I understood that, am I going to financially hurt her in some way? But trust is a big issue with these people.
For both of them, or just the son?
Just the son. No, she trusts me completely.
Okay.
But I think he trusts me now too.
Okay. And I think if you approach him with your concerns, I mean, he can only feel positive about that. And he can only feel positive about your interaction with his mother.
Any other questions or input for Anne?
Thank you for this everyoneon.org. I haven't heard of that. For low cost internet and low cost technology. I will look into that.
Of course, it's been
Wonderful.
useful for some of our clients too, because we did a technology survey actually amongst all of our clients and found out that about 40% of them don't have access to internet.
That would be wonderful. I'm sure she'd be interested in getting it if she could afford it.
Thank you so much. Anne, do you have any other questions for us, or were we able to answer your question?
You gave me some great ideas. Thank you.
Yeah, wonderful.
Yes,
Looks like we have 4 more minutes. Geraldine, I know we had some quick questions in the chat before we moved on into our case. Somebody asked, I would like to know, how do I help someone who has the symptoms of mental illness? All right, hold on one second. Somebody asked, I would like to know how do I help someone who has symptoms of mental illness, but they're in denial?
Yeah, I think a lot of people are in that space. You know, we want to help. The best thing I think we can do is to get them connected with an expert. So getting them, encouraging them to seek their primary care physician, or talk to, you know, a specialist or an expert. Is what I would do. I don't know that. I think it's incredible that you're sensing that there's more than the distress, right? That this smells a little bit more clinical. This is more than personality or situational, and saying, you know, very much to something like, you know, thank you so much for sharing. You know, what you share with me really, really matters. And I wonder if I could get you connected with somebody that could help us, and kind of aligning with them and not saying, here's who I think you should see, or here's who I think should be the next step, by saying, I think I know somebody that can help us, and making that a joint effort could be fruitful.
Thank you. And somebody also asked, is it safe to say when meeting with a client that it's mostly listening to the client than talking?
Once again?
Is it safe to say when meeting with a client that it's mostly listening to the client than talking? Joe wrote that.
Yeah, I think.
I don't know if you have, yeah.
Yeah, I think in the beginning, especially when you're trying to build rapport, Joe, that's a great question. You listen, and you're taking mental note, and you're holding space. That's what you're doing. You're holding space, and then you just build on it. The next time you meet, you're going to remember something from that last conversation, and you just keep building. So I think what you're doing is really important.
Thank you so much. Thank you so much, Geraldine, and thank you so much, Anne, for this session today. We had some really great tips and conversations, really productive meeting. Thank you so much. I did want to remind you guys, we only have 1 more minute, so I want to do our closing. If you do want CE credits, please make sure you fill out the CE form that's going to be sent out following this session via email. And then we love your feedback. We love your recommendations for future topics. Please be sure to fill out the session evaluation as well. And then in 2 weeks, on May 21st, we have our next session, which is our 3rd session on changes in condition, dementia, and stroke, presented by Dr. Sonia Stagel. So we hope you all will be at that session. It's always going to be the same Zoom link. I know I got some questions earlier today. People weren't sure how to join. It's always going to be the same Zoom link as today and the last session. I always try to send it out like the day or 2 before, so check your email. You should also have the calendar invites, but it's always going to be the same link. So we hope to see you on the 21st. And look out for that email with these links and the presentation. And then we'll also be sure to send you the video from today. Thank you all so much for joining us.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.